All right, listen up. This is your tactical masterclass on acute interstitial nephritis. I'm Dr. Collins. Let's move. Core Intel. Acute interstitial nephritis, AIN, is an allergic firestorm inside the kidney. We're talking a type 4 hypersensitivity, and it's almost always triggered by common drugs.
Forget the classic triad you learned, fever, rash, eosinophilia. That's a trap. It only shows up in 10% of cases. Rely on it, and you lose. Your targets for diagnosis are two key traces. That's it. White blood cell casts in the urine and sterile pyuria. Think pus without the bugs. Got it? The offenders, lock them in with the 5 Ps. P for pain, diuretics. P for pain, NSAIDs, penicillins, PPIs like omeprazole, and rifampin. Memorize it.
Primary objective, stop the drug. Immediately. Steroids might preserve GFR, but that's secondary. The mission is simple. Know the drug, find the cast, save the tubule. Let's go! And now, before we proceed, our mandatory international medical disclaimer.
This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
All right, Sarah, let's really get into this. You know, AIN can be a real diagnostic headache because it's the perfect mimic of a simple urinary tract infection. So let's think this through. You've got white blood cell casts in the urine, but the culture is negative. Why does that immediately tell us the problem is in the kidney and not just some bladder infection?
Well, it's about the anatomy, Dr. Collins. A cast is a mold of the renal tubule itself. So if you see one, it's like a fingerprint from the crime scene. It's definitive proof the white cells are coming from deep within the kidney parenchyma, not just floating up from the bladder.
Exactly. And that sterile pyuria, that's the signature of this allergic reaction. The kidney's interstitium is basically a war zone, but it's full of T cells and eosinophils, not bacteria. It's an immune battle. And, you know, it's crucial to remember that nowadays, proton pump inhibitors like omeprazole are the #1 cause we see.
Precisely. An immune fire, not an infectious one. So let's bring this to a test question. For the boards, how do you nail the difference between AIN and acute tubular necrosis, ATN? It really boils down to 2 things, the patient story and what you see in the urine sediment. For ATN, you're looking for muddy brown casts, usually after some kind of ischemia or toxin exposure. But for AIN, it's those white blood cell casts we've been talking about because the root cause is that allergic hypersensitivity.
And to really clinch the diagnosis of AIN, you'd look for supporting evidence. You know, check for peripheral eosinophilia, maybe even do a Hansel stain on the urine to spot the eosinophils directly. But at the end of the day, the single most critical first step is always finding and stopping that offending drug.
Okay, now I've got a question for all of you watching. Think about your own clinical experience. Have you ever diagnosed AIN from something as common as an NSAID, where the only thing that tipped you off was a rise in creatinine? We'd love to hear about your tough clinical catches, so drop them in the comments below.
All right, Sarah, time to lock and load the 5 Ps, rapid fire. You ready? Ready.
P is for P, diuretic.
P is for pain, NSAID.
P is for penicillin.
P is for PPI, omeprazole. Last one. P is for rifampin.
What's the critical trace? The WBC cast is the key you chase. And the command? Stop the drug, make your stand.
The interstitial fire is contained. But listen, if you can't navigate the acid-base chaos left behind in the tubules, your patient's electrolytes are going to stay a mess. Your next mission? Master renal tubular acidosis. Watch the RTA module now.